Good morning, everybody. Can you hear me? Yeah. So I'm David Kirk, and Janine. We're going to talk to you about our journey for modelling the 5-year forward plan for Leicestershire and Rutland. So we'll start with giving you the context of where the initial request came from. So, as is standard, the ICB had some sessions planning out the strategy on lots of flip charts. These were then worked up into some slides. So I won't go through all of them, but I'll just pull out two areas just so you can see where the complexity was coming from and what they wanted to achieve. So this is just looking at primary care. So what they wanted to do was change how people access primary care. So if you're otherwise fit and healthy, you go through one particular route, either through the app or online or on the phone, and then you'd be triaged. And then that triage might lead you to a GP appointment or a specialist appointment, but it's more likely that you would go into things like the pharmacy and physio, that type of thing. So redirected that way. But then there's another route. So if you've got long-term conditions, multi-mobility, frailty and end of life, you would then go through the phone call into a different triage, and you're more likely to get a GP appointment or a specialist appointment where your current challenge could be seen alongside all the other things that you are dealing with as well. So that's just one aspect of primary care they wanted to change. Then go right to the end, they want to look at discharge and how we manage discharge. So this was the opposite to the primary care. So here it would be, no matter where you were being discharged through, you would go through one particular route where it'd be managed, and then you'd be redirected and supported either to the home, care homes and things like that. So it's just giving you some context of what some of the things they were looking at and what they were asking us to model. Which then, at the end of the sessions, it was, can you build us a model to look at this, to look at outcomes in terms of finance, workforce, performance. So our initial reaction were these questions. So is there something we could just pick off the shelf and use? No. There was lots of bits, lots of interesting things, but nothing that really gave us the ability to model all of those things. Do we have the required data with the required quality level? Not really. We had good data, but some of the things that they were wanting us to model, the outcomes, we don't even collect that information. That would be part of the new system. Do we, within the ICB and for the CSU, do we have the modelling skill set and, more importantly, the capacity in that skill set? No. We have lots of people with really good skills, but it's spread across the areas and the capacity is in demand, so taken up. And lastly, the most important thing, do we have people within the ICB ready to receive the output from these things? Are they on the same page? And they know what they want the plan to do, but in terms of us coming and talking about modelling, are they ready to accept it? No. And then that last point, it needs all being done in a month. So we took a step back, and with all of that, facing all of those things, we still had to produce something. We still wanted to do something that was useful for people to move forward with the plan. So we took a step back and came up with a very, very simple adjustment model. So it needed to cover all the major elements of activity, so primary care, inpatients, outpatients. Took into account demographic changes, so looking at the population changes in our area. We wanted it to be able to allow people to adjust the rates based on what schemes and plans they were putting in place, what they felt would happen. It must be simple but non-simplistic. It's complicated what we're trying to do. Must be transparent to gain trust, so it would actually support the 5-year forward plan. And must be accessible so people can inform the rate changes. So this is what we did. Excuse me, big screen. So this is just GP appointments, and one of the things they wanted to look at was the type of appointments and changing that. So it's very simple Excel document. You've got the historical data, and then that just moves through year after year. So there's only 2 years on there, but we did it for 5 years. And you can change the peach boxes effectively. So you can change the total number of appointments. That could be because you're putting certain schemes in, or it could be because of the demographic changes that we see coming through. And you can change the proportions of the type of appointments. So put that in place, lots and lots of Excel worksheets, working with people, but it didn't work. Even though we had a simple, accessible model, it didn't work because we were trying to model something that was far too complicated. So we were working with people and they were saying, well, I know what scheme I'm doing, I know what impacts I want to do, but actually coming up with a percentage or rate they really found challenging. And then also there was the impact of one area on another. So if you change this, how does that impact on the A&E attendance? How does it impact on those other areas? So what we came up with was far too simple in the end. And so we changed TACT, which is what I'm going to hand over to Janine.
So we were trying to do far too much, far too quickly, and we weren't able to bring people with us on the journey because we were trying to do it far too quickly, so it needed to change an approach. So we broke it down even more and actually started to think about how we could take a PHM approach to different parts of the pathway. So starting with kind of, for different elements of the 5-year plan, what does the needs assessment look like? How will need change over the next 5 years? Where are the opportunities to make change? Where are the things in the pathway that we do actually want to see differently over the next 5 years? But also the really important bit, where can we have impact? Once we understand health needs and the opportunities, actually what are the things that we can change with our interventions and pathways we put into place? So we started with a very simple base activity model that looked at demographic change. So over the next 5 years, our population will grow by about 4%. If we look at our kind of age-weighted hospital activity levels, our non-elective activity will increase by 8% if our population continues to consume activity at the same level. So the growth in non-elective admissions will be double the rate of population growth. So if our investment stays in line with population growth, we'll be growing our activity at a rate far above that. So unless we do something differently, we won't be able to sustainably deliver healthcare for the population in the same way. This is such a flawed methodology, but we've been trying to model through what will happen to our different population segments as we go through. The reason this is really flawed is the data that we're using. We are trying to increase diagnosis of people with common long-term conditions, so that's all fundamentally built into the model, but we think that kind of we could have up to a 25% increase in the number of people on long-term condition registers over the next 5 to 10 years, which is huge. So it will change health needs, it will change demand, it will change our service use over the next few years, and that's a combination of kind of our aging demographic, but also the combined risk factors, but also the fact that we're actually just doing an awful lot of work in primary care to increase diagnosis, management and treatment of patients earlier in the pathway. So we then started to think through, right, so we know that needs are going to change, we know that we've got this tidal wave of people with long-term conditions coming through, so we cannot continue to just roll over our contracts and increase them in line with population growth. We're working with clinicians around the CVD pathway, largely because the evidence around CVD is better than the evidence for any of the other long-term conditions. But we've got some really engaged clinicians, and one of the things we've learned through the work that we're doing is you have to bring the clinicians with you and you have to bring the managers with you, so you need to build them into the work that you're doing. We've got a whole raft of CVD interventions that are linked to kind of case finding, but also improving treatment. So we've been trying to kind of work through these and actually model through the impact of each of the interventions that we've got listed here, be they through case finding or be they through optimising treatment, and trying to kind of work through what that will mean for our pathways of care. I'm not going to run through all of these. But again, this is quite a nice one. This is quite a nice slide just to put out why we're looking at CVD. So overall CVD accounts for 6.1% of all of our NHS inpatient care. It accounts for over £46 million worth of spend for the LLR system. So we're spending an awful lot of money in secondary care on cardiovascular disease. And we know that it is very receptive to earlier interventions in the pathway. But it also accounts for over 13% of our bed days, and we need to manage the amount of time people are spending in beds because that's where our spend really is in terms of the pathway. So we've broken down all of the interventions that we set out there, and the one that I'm showing is just around optimisation of hypertension treatment. This uses the PHE CVD return on investment tool, which I can call PHE because it hasn't been updated under OHID. And basically all we've modelled into here is the optimisation of hypertension treatment. So it's been around improving the detection of hypertension in our population to 80%, but improving the management of hypertension to 80%, kind of based on NICE guidance. This is a really nice tool. It's really complicated. It's quite hard to get your head around, but it gives you some really good outcomes. It gives you some really good outputs to build into that model. So just looking at CVD events, by optimising detection and management of hypertension treatment, we could prevent over 1,000 CVD events in 5 years. That's huge. We could prevent 61 premature deaths, so we could save the lives of 61 people just by managing hypertension better. And the savings are enormous, so even with additional costs in primary care, because we are shifting care back into primary care, we still have the potential to save over £10 million of costs. Some of that saving is in primary care, but most of it, over £7 million, is in secondary care and £5 million is in social care. So just kind of taking this kind of approach, we can start to think through how different bits of our pathway interventions can interact with the model that Dave started to build, so that we can actually say, if we do this, we can actually have a phenomenal impact on people's health outcomes, but also on the profile of our pathways that we're working with across the system. And start to think about how we can actually reprofile our spend, so that we're diverting activity away from social care, away from secondary care, back into primary care and back into prevention, and it actually gives us the power to open up some of those conversations. But where are we? Oh, stop. Really quickly, where are we? We've done loads of work. It's really complicated. It's really difficult. We haven't failed because we've really started to open up. We've been using data to open up some really complicated conversations. We've got a huge amount more work to do in this space, and we're really interested in partnering with other people that are doing anything in this area, because I think there's so much we need to be doing that learning together, and we need to be working together on some of this.